Good morning, my respected teachers on the other side, and to the chairpersons. While sitting there, on a light note, I was feeling like my college days when I was allowed to go to bat on the crease on the 7th down or the 8th down, when all the better players have played, and on the next match, my name never came up on the list, because on the 47th over, I got down and I made only 3. So this is old is gold, and I have taken this presentation on a different side. Well, for an echocardiographer like us, we do echocardiographies not always in our own clinic, in other clinics too. And patients do come down to us from the other physicians or the other cardiologists or the other cardiac surgeons. When they come down from their table, they turn around and ask us, "Sir, kiram dekh len? Sir, kaise dekhe mere ko?" It is always a very heartening part on the part of the cardiologist or the echocardiographer there to say, "Arey, you are perfectly well. Sir, last time I was 35% ejection fraction. This time, I keep on telling them, "Sir, let me assure you with my clinical experience, human beings are not just figures. If you are doing well, your doctor has kept you well." History has been written by people who have won the war. And this is the war-winning history from the cardiac surgeons. To introduce, the valve replacement surgery came up in 1960s. Approximately half of the mechanical valves and half are prosthetic valves. Valve replacement does not provide a definitive cure to the patient. It just changes the native valve to a prosthetic valve, just to add up the quality of life to the patient. Sometimes it does, sometimes it doesn't. The outcome of the patient is affected by the prosthetic valve hemodynamics, durability, and the thrombogenicity. And the ideal valve substitute should have an excellent hemodynamics, a long durability, a low thrombogenesis, and an excellent implantability. So this is my first case. This was a 47-year-old female patient with a mitral valve prosthesis done way back in 2008. And these are the pictures. The patient definitely had a tricuspid regurgitation. And our finding was the valve was monoleaflet at that time, Medtronic Hall. Prosthetic mitral valve opening was adequate. Atrial fibrillation was seen. No significant LA clot, as much as I have seen on the TTE. Mitral valve area by PHT was almost 4, the gradient being 14/6. There was significant tricuspid regurgitation, and the gradient was 19. So these are the different types of prosthetic valves that were used. And the second case was this. This was a 64-year-old female patient with an AVR done in 2008. These were the echoes of the patient. And the gradients were also acceptable. If I can read, the aortic valve gradient was somewhere around 14 in the mean. And this was the LVOT gradients, because the AVR done was in 2008 in these patients. There was a mismatch, because at that time, perhaps as much as I have gathered from the history, it was a 17-millimeter valve used. Later, the aortic valve root was dilated and 22 was put in. And then with a tissue valve. Now it is a functioning tissue valve in the aortic region. The peak being 2.6, mean 16.4, The EOA was 2 by continuity equation, and the DVI was 0.34, which is very well acceptable. There was no AR, no leak. This was again another case. This is a 60-year-old patient with a DVI done 20 years back. And you can always, you will see that this patient has a cage ball valve. And this is how the cage ball valve looks like on the echo. So this was the color Doppler signal done. The aortic valve function was also okay. And this was the Doppler like. So the mitral cage ball valve was there and the aortic tilting disc. That was also probably a single tilting disc. Both valves are functioning well, no significant LVH. 11/10 was the figures, good LV function of 61%, functioning both valves. The mitral valve orifice by PHT was 3.2, gradient being 13 and 5.5. TR gradient was 22. Aortic valve was 1.4 square centimeter by continuity equation, DVI 0.39, and the gradient was a little bit high on 21 and 13. This was a 40-year-old patient with a DVR done 15 years back. And these are the color signals like. This patient had a tricuspid valve repair done, and the tricuspid regurgitation was there. So this was the valve like. It was tilting valve. This is again a 40-year-old DVR patient was having a good LV function. There was a mild LVH, 11/11. Both prosthetic valves are functioning. MVO was 2.3. There was a trivial MR. In the aortic valve, the ERO was 1.07. Diverification index being 0.28, just a little bit on the right side. AV gradient was 38 and 21. TR gradient was 22. This patient ultimately had a syncope, but we found out that the syncope was because the patient was having a sick sinus syndrome, which was having a very big pause, and the patient was taken up for a permanent pacing. Now, this is an 18-year-old male patient who presented to us with increasing shortness of breath, palpitation, and night sweat. And then history was there 6 years back. He was operated for a LA myxoma. Well, this was the pre-op echo 6 years back. I could gather from the patient. It was a plate, and I have put it up. This was showing an LA myxoma. This was there. And now, what we found was this. It was a lobulated mass from the right atrium. It was protruding through the tricuspid valve to the right ventricle, and of course, it was a myxoma. The patient was taken up again for a redo operation. It operated, and you can look that the myxoma that came out was exactly like what we have seen in the echo. It was a lobulated one. It was a post-op case of LA myxoma. The echo revealed a recurrence on the right side. The new right-sided myxoma obstructing the RV inflow. The RA myxoma was lobulated in appearance from the echo, which was substantiated from the operation specimen. Patient was followed up twice after the excision, and he is now doing well. So this was a little bit of literature. Sporadic cases have very low recurrence rate in LA myxoma, 1% to 3%, whereas patients with familial forms and complex forms have a high recurrence rate of 12 to 22%. And those were written in a very low ink. It was patients with cardiac myxoma were associated with a recurrence of up to 30% of cases, whereas the total population of cardiac myxoma reported rates of recurrence vary from 3% to 6%. Cases up to 4 to 7 recurrence were also seen in single patients have also been reported in my cases.
Thank you, Dr. Paramartha, for nice presentation of the late cases. Any questions from the audience?
How do you define delayed? What is the cutoff figure in terms of time?
Sir?
When you say delayed complications,
No, I have not shown any complications, sir. These were all the success stories of the surgeons.
The subject is late postoperative.
Yes.
So what is the late?
I delayed because these patients are all taken up after 16 or 20 years after the operation. And I believe the cardiac surgeons, sir is there, he'll tell you that 20 years before what we are today, they had lots of problems in taking these patients up to the OTs. But these patients, after 14 or 16 or even 20 years with a DVR done, the patient is doing pretty well. And then when they come down from the our echo table, we can tell them, you are doing well. You are not having shortness of breath, you are not having palpitation, you are doing well. And that fills us with a sense of joy. I wanted to keep those success stories in my presentation this time because sir will say the rest of the story. Professor Bhattacharya is there. He will say the success stories of the surgeons of that time.
Most of the success stories are related to LA myxoma.
No, sir. This LA myxoma
what was your maximum late period following surgery that patient developed complication or remain complication free?
It is generally, sir, 20 years down the line with a valve surgery, the patients are doing well. That has been from the literature. So these patients are also doing well over 15, 16 years or 20 years. That's why I had kept these patients.
Since we had many of our patients with rheumatic origin, so obviously we had both mitral and aortic valve disease. Now, because of the flow differences, the difference in the outcome or difference in the thrombosis or thrombus formation is there with aortic valve and mitral valve. One is slow flow and one is rapid flow. So clinically, is there any significant difference in the outcome between aortic valve and mitral valve replacement?
Clinically?
I mean, in reality.
In reality, sir, what we have seen clinically, sir, those mitral valve replacement patients, they tend to do better. Of course, mitral valve replacement, after mitral valve replacement, we do have more of these stuck valve lesions. They come more in the hospitals with mitral valve stuck valve lesions rather than the aortic valve, because probably of the high flow region in the aortic valve, they wash off those small, clots well.
Any question or comment from the audience?
I have one patient, the ball valve ball cage valve was given 40 years back, and she is doing well, still in the fall-off.
I think it also
she is 70 years old, 30 years that is, he was given the cage valve thrombus.
What was that valve disease?
Mitral valve, only mitral valve.
Actually,
mitral stenosis.
Tell you one thing, that I started my career in this surgery in the 84, and different evolutionary changes occurred after that. At that time, Anyanda was also in the PG, and cardiologists used to tell us CMB was the main operation. And even in mixed valvular lesion, cardiologists used to tell us that please do the graded CMB so that at least PND can be relieved. And at that time, the conception was that if we remove the mitral valve pathology, then the tricuspid valve will automatically be recovered. But that was not so. Our conception was wrong, and tricuspid valve also is a progressive disease that was proved. And according to that evolutionary process in the management of tricuspid valve also came out. And that different, first we used to say, implant the tilting disc valve, and then came the ball and cage valve, which was at that time much cheaper. And in the government sector, in the poor patients, many cases we used to implant the ball and cage in the mitral position and the disc valve in the aortic position, because at that time size of the ball and cage valve in the aortic position was not available to that extent. And in this way, after that came the bilibrate valve, and by this time, in the eastern zone, we got from Professor Baliatan sent us out 25 Chitra valves, and in the year 95, we used to give a trial on Chitra valves. And in the 2000, then these valves again changed to the bileblate valves, and Chitta valve also proved its efficacy. We are still now using the Chitta valve, though the Chitta valve also has manufactured the bileblate. In this way, there was a lots of evolutionary changes in the valvular process occurred, and even we got the conception of the patient prosthetic mismatch. At that time, when there was difficulty in putting the 19-sized valve, the surgeons used to think a lot what to do. Then came the 17-size valve, or sometimes a person of height about 6 feet and weight 75 kg. It is very difficult to keep in the double valve replacement 17 in the aortic position. So came the question of root dilatation. In this way, evolutionary process.
In fact, talking about the valvular disease, surgery, medical, or whatever, is a sweet journey down the memory lane. And I think the rest of the memory lane would become even richer by our experience. Thank you very much. Thank you.
Thank you, sir.
Thank you.